Good morning, Betty. So good to see you
Hey,
here
Sonal.
today. Oh my goodness, my friend. We are on for another Compliance Capers session together on this Friday morning. I am so happy that you're here, and we're going to be talking to our audience today about, even more capers that we see going on in this industry that we're in. And, these capers are published quite publicly all the time in our findings on OIG websites as well as the DOJ, right?
Yes.
They provide these press releases weekly, daily, monthly. They do it all the time. And
Yep.
so, what we really wanted to go over together in our talks, our conversations, lighthearted, just, quick bursts at the end of each week, hopefully. People want to remember compliance, right? That was the whole goal of this conversation
Yes.
being held on Fridays, because I really wanted the audience to kind of have an end cap to their work week, right? An end cap to remember that proactive compliance, definitely in our opinions, is way better, right, than playing this game on the back end, right, of receiving
Yeah.
these types of correspondences from the government when they find out these wrongdoings that have been going on. So we
Yeah.
really try to stress to people who have found us on Compliance Capers that you don't want to be involved in these types of stories. You don't want to be involved in these types of
You
big
don't want
bad
us talking
papers.
about y'all.
Yeah, no, you really don't. Yeah, we see it across the country, and I know personally we haven't had any of these big press release cases, which is a good thing, which is why we can talk about it. Again,
Yes.
vaguely in generalities, you guys can all look things up for yourselves and kind of figure out what case we're actually talking about. But we are very vague on purpose on our
Yes.
conversations because we really want it to be educational,
Yes.
because we do go deeper in terms of the actual coding mistakes and errors that might have been going on in these cases. Again, simply because my good friend here and I, we are certified coders, we are certified medical auditors, we are compliance professionals. And so this is the type of work that we do every day. And we are well aware of the vast variety of specialties that are out there, and we do, have our pulse on what is going on in the current code changes, especially here we are already in
Yeah.
2024. And there's a bunch of new CPT codes and a bunch of new HCPCS codes, and of course, all of the new E&M guidelines that have been going on now, right, since 2021, 2023, and we definitely have some more guideline changes right now in 2024.
Yep.
So, these capers are huge, but in terms of what we really wanted to try and dive into for today's conversation, is going to really piggyback from a previous conversation that we had together. And it involves upcoding of services, right? When it comes to that term upcoding, I know we hinted at this last time that it is a CMS construct, this term of upcoding, right? It's not a good look, right? When you're upcoding something, that means you're trying to elevate the service and not be as honest
Yep.
in terms of what you did. And again, that's to gain more reimbursement. So, my friend Betty, I'd love to hear from you on what case we've pulled for our conversation today in terms of upcoding services and what went wonky in this case and what did they do?
Yeah. Wonky's a good phrase.
Yeah.
The one that the one that we pulled is about a company that is doing biotelemetry, and it was their siblings, brother and sister, allegedly. They are headquartered in Pennsylvania and out by you in Rosemont, Illinois.
Oh, so
So
close. Oh my
I
goodness,
know.
that's so close to me. Uh-oh.
Well, last episode we had Florida, so we hit my
Close to you.
territory. So
Okay,
this
okay.
time,
So now it's my turn. Okay, okay. That's fair. That's fair.
so what this company allegedly has done, because they settled, but they settled for more than $14.5 million. So, but allegedly they were getting orders from physicians for Holter monitors. And what the Holter monitors, they're hooking the patient up for the EKG, and they wear it from between 24 to 48 hours. And when the patient feels they're having an event, they like hit the button and it records it. And then after it's been worn, they remove it. Then it goes to be read, all the events, they read it and come up with a report. Now, they also have cardiac telemetry, which with the telemetry, they hook it up, but it's now real time. It goes to like the cloud. And then they have a group of people that monitor it. And when the patient's having events, they're looking at them in real time, and they can even notify the physician or the APP, whoever ordered this for the patient, and let them know, hey, this patient's having arrhythmias that are going on for this long. And, so it's a much more detailed, involved process when they do telemetry versus a Holter monitor. So what this company allegedly was doing was, when they would get the Holter monitor orders, they would hook the patients up for telemetry anyway, and kind of ignore what the order said. Or if the order was kind of vague, like the physician or APP who was ordering it wasn't sure exactly the verbiage to use, they would go ahead and hook the patient up with the telemetry because it paid a lot more. Now, with the Holter monitors, you're looking at the CPT codes from 93224 through 93226. And if they do everything, they do the recording, they do the connecting, all of that stuff, the global fee for it is like $73.54, around in there.
Okay.
And then if they do the telemetry, which is over 30 days, the monitoring for that in real time continuously is like $849.55. So you've got a huge difference in what this company is being paid for doing something other than what they were ordered to do. And so that's kind of what was going on there. And they knowingly did this because the telemetry pays a lot more. Allegedly, they knowingly, allegedly did it. So they're having to pay, all of that back to the tune of, as I said, over $14.5 million to settle this, which means that it might have even been higher, but this is what they settled for. So it's just not, once going back to, again, our previous discussions, the money into the program, and there's a finite dollar amount that we have out there. So when these people that are pulling these capers and, getting all this money that they don't rightfully deserve, it's taking away from all the other things that, we need to be spending it on, and we need to be giving it to our physicians and APPs and facilities that are doing the right things. We need to make sure we have funds to pay those things. So that's what these guys did.
That is unbelievable, right? That they just skirted doctors' orders. They just didn't care.
No.
That is appalling, right? So they could pocket more reimbursement. There's a big difference there between $70, what the doctor actually ordered, and the telemetry, which they knew they could receive just around, $900 for that. That's insane. So the reimbursement difference there was the motivating factor for this paper, for these people, for this duo, right, of siblings to take this on. That is crazy, right? So when these types of cases come to fruition, right? That's when you and I really dig our heels into these types of reports, press releases, etc., right? Because we can really dig in again, refresh ourselves on these types of services, right? Where the guidelines are clearly outlined in CPT, right? For these types of cardiac monitoring services. There are guidelines written right there in our CPT books. A whole section is carved out for those types of service lines.
Yep.
And it's a shame that in this case, allegedly, right, the providers just did not know that this company was doing that to their signed orders, right? They
Yep.
sort of manipulated everything and just did what they wanted. And, after so much time, this company was found out. And like you were saying, hinting at, allegedly they are settling for only this amount. It could be a lot more, right?
Yep.
That was actually being billed out. So yeah, it's egregious what this company had done. It's terrible. And, absolutely true. The Medicare Trust Fund is depleting. And, we wish there were better ways to catch these kinds of
Yeah.
fraudsters earlier, like catch the fraudsters in the act much earlier, um, and address the situation much earlier. So again, the amount of recoupment isn't in these millions of
Yeah.
dollars,
Yeah.
$14 million
Yeah.
and more.
And looking and looking at it, when you said that, I just went back.
Okay.
It was from 2014 through 2020. So 6 years.
6 years, you see?
Yeah.
So it's like, yeah, I wish there was a way to, have caught them earlier, like right then in 2014, like right away, just within those few months of that year. Um, that's something that you and I talk about a lot is there has to be better systems at play,
Yeah. Yeah.
processes at play on the payer side, right?
Yeah.
Because you and I do a great job on the provider side trying to
Yeah.
put these stops in place at practices to make them check on what they're doing before
Yes.
they're pushing claims out the door. So we know we're trying our very best on the practice side to help, but on the payer side, there has to be a lot more ways that they can implement some sort of stops, like hard stops, once they see a certain threshold being met. Just go ahead and shut that down immediately instead of stretching it out for all of that time and then allowing those types of companies or entities to receive erroneous reimbursement like that for that 6 year period of time. That's
Yeah.
also
Yeah.
appalling.
Well, and they look at just that specific period of time, but this was released out in December 2023. So,
Yes.
like from the December 2020 till December 2023, it's not like they
2023.
stopped doing it.
Right,
So
right, exactly. Yeah, yeah.
that was just the
True,
time period they were looking at.
true.
And it just, the whole pay and chase thing, I just,
Yes. It's
it
awful,
doesn't really,
awful.
it doesn't work that well.
It doesn't work.
And
No.
for everybody who's going nuts about all the prior authorizations, right?
Yeah,
When you think
yeah.
about that, why do you think they have to have them? They have to have them because of stuff like this. People
Hmm.
doing all these things that aren't medically necessary, that are up,
Right,
so they do all this
right,
stuff. So the
right.
money's going.
Hmm.
Well, so one of the payors things to try to stop some of that is, well, we'll have to make you authorize everything then before you get it done. Well,
Right,
if some of this stuff wasn't going on, maybe we wouldn't have all that prior authorization craziness that we have going on now. I
right.
mean, that's finally they've had to step in and start. CMS is like, hey, we got to cut out some of this stuff. It's just getting nuts. But on the payor side of it, they're like, well, unless we audit every single person that sends us claims, what else are we supposed to do? So it has trickle down
Yes,
effects on
true.
other things that are good. and compliant practices are doing, and they have to jump through a lot of these hoops because of these fraudsters pulling all of these capers and depleting our resources for what we have to pay for healthcare services. It's just nuts.
Absolutely. My gosh. Yeah, we are ranting. Yes, absolutely. Because the money is depleting. Absolutely true. Yeah, and prior authorization is through the roof in our industry, right? So that's yet another hoop that our providers have to jump through, right? They already do enough hoop jumping, in my opinion. They do enough,
Yeah.
right?
Yeah.
And this prior auth stuff, that's a great point. That's why so many more service lines require prior authorization, because of this back end mayhem, that each of the payers is actually seeing, right? From
Yeah.
commercial to government and anything in between. They are seeing the mayhem. And so they're like, well, we're going to put a stop to it and make you jump through more hoops, and wait for some more time before we can allow those claims to go in and come into our possession, right? Because we need that prior authorization first to make sure that you are meeting all of our criteria for those services based on our policies. So,
and so then you've got patients that are waiting for necessary,
which is
needed
sad.
procedures
Exactly.
because they're waiting for the prior authorization. And so from that patient care standpoint too,
Yeah.
now you've got patients that have to wait for stuff that they actually need because having to go through these processes, because we've got these people pulling all these capers out here that are causing all these massive takebacks. And, for them, from the payor side, when you look at some of these settlements and some of these cases where, they've sentenced people and been found guilty, that takes a lot of manpower on the payor side too. So, I mean, when I get clients that have had ADRs, and so they're coming to me, those additional documentation requests, and they're like, oh, they're requesting 150 records and blah, blah, blah. And I start looking at it. Well, that takes the practice's time to pull the records and to put everything together. Then they have to pay me to take a look through them and make sure, oh, is this missing? Is that missing? Or, I see that there is an issue here, so that we can get in front of it, with the payor and say, hey, we really didn't know, but we had a consultant look at it and we found that, these things are there, and, we get on the right track, but on the payor side, we were talking last time about the adjudication, right?
Yeah.
Goes electronically from the practice or the clearinghouse over to the payor. Nobody looks at it. So on neither end are there bodies being put on this at that point. It's just all digital. But once they start and put those ADRs, once you pull all those records and stuff and send them, somebody over there has to look at them. So now the payor is putting bodies onto something that they're looking at. So it's costing them, to be looking at stuff. Now, I know that sometimes we also get clients where they're pulling stuff and asking for records when you're like, oh, really? Come on, where it seems like the payor's picking on them a little bit, kind of thing, or fishing. And, but, you get these other things where there's something valid there. They've put a lot of bodies on that, to look at that documentation, to look at those different things, as you were saying before, to calling maybe patients, talking to the offices, talking, all of that is resources that they're spending to try to get some of this money back.
Right.
So, they're looking for ways where they don't have to do so much of that. And the prior authorizations is one of those ways to stop some of that. But that just makes it a migraine for everybody, having to go through that. Because, you're talking to somebody over there at the payor side or going through things if you don't agree with one of their prior auths. And, so now you've got the argument going back and forth, and, it just elongates that process. And again, the poor patient is the one that's waiting for some kind of procedures that they need to have done, and can't get done now because of all this mess that these other people are doing. So it just causes problems all throughout, the healthcare field. Plus it makes us look bad. You see this stuff on TV, on the DOJ thing, and that's, some people are thinking, oh, all those doctors are
All
crooks and all
doctors are
those
the
places.
same. Right.
It gives us a
Right.
bad reputation out there, and that's
Yeah.
not good for our field.
Agreed, Betty. Yeah, I agree with everything you said. Absolutely. Our patients are the ones who are suffering the most with all of these capers, right? Absolutely. The trickle down effect is huge and at the center of everything in today's, conundrums based on these fraudsters and these capers it's the patients. And you and I know plenty of people ourselves who are the ones that are suffering, who
Yeah.
don't have the time. They can't get in for the procedure because they are forever waiting. They're playing the game as well. They didn't want to be a pawn in this game, but they are. They're
Yep.
now pawns as well, right? It's incredibly torturous. It's incredibly sad. And I agree with you spot on. You're absolutely right. Is we all get a bad reputation in this industry, right? It affects all of us. Our providers are looked at like everybody's then horrible and they don't know what they're doing. They don't know how to practice good medicine.
Right.
They're all in
Trust.
it for a buck. There's no trust. Where's the trust?
Yep.
Right? Yeah, I have this conversation with my physicians, friends who are doctors, family who are doctors. The reputation, the illustrious reputation of the past is gone. There
Yeah.
is no more glorification of our healthcare providers. There's
Yeah.
because that trust is eroded. It's gone. It's long gone, right? And so unfortunately, that's a very dark lens now that is put on to our providers in this space, right? And so we see the numbers, less and less young
Yep.
people want to get into
Yeah.
medicine. Like the medical student applications are decreasing year after year.
Yep.
So who's going to take over, right?
Yeah.
Who's going to take over? And so there's all of that storyline as well
Yep.
that happens based on these capers. So it's not just a caper, right? There's
Yeah.
so much more involved, so many other factors of society at large that are being affected by these types of folks who make it on these hit lists.
Yeah. Yeah.
Yeah.
Yeah,
So,
and from an office standpoint, for those offices that are, doing the right thing and they are
mhm,
compliant or trying to be compliant and do things, looking at this upcoding of services, just like we had talked
mhm,
about the upcoding of E&M on the other episode,
mhm,
you just want to make sure that if you as the physician or APP are coding these services yourselves, make sure that you are looking into the CPT book, look at the guidelines, what the guidelines are telling you, and make sure you're reporting only the services that you're providing. And the right ones, like the Holter versus the telemetry thing,
mhm.
to make sure that it's reported correctly. So you're getting paid the correct amount. Most of
That's
my
right.
clients, when I talk to them, the physicians are like, I don't want to be paid more than I deserve. I
That's
certainly
right.
don't want to be paid less than I deserve.
Right.
I just want to be paid right. I want to be paid what
Mhm,
I deserve for it. And
mhm.
that's the attitude that we want with the practices.
Yeah.
If you're the coder or a billing service that is doing these, just make sure you're following the CPT guidelines and reporting the services that are documented. Make sure
Mhm,
they're documented correctly. If there's a question about, is it this service or that, because in CPT, sometimes when I used to teach, certification classes, sometimes we would look through blocks and subsets in the CPT sections. And, sometimes it's like, oh, isn't that the same thing? Isn't that code the same as that code? And, sometimes they can look pretty
mhm.
similar.
True.
But when you look at it, sometimes there's an and, or there's the word
Mhm.
expensive, or there's numbers where it's
That's
1
right.
to 14 or 15 or more. There's going to be something in the
Mhm.
code that differentiates it from the other code, or they
Right.
wouldn't have two codes, right? So
Right.
what I would teach my students to do would be to highlight, when you get to a block like that, especially like in the scopes, how they'll have the
Yeah.
one scope and then, go through
Simple down.
and
Yeah.
highlight where it's different. If
Yep.
one is and one is or,
Mhm.
highlight that that's what it is, that this one is only if you do both, but this
Right.
code is if you do either one,
Mhm.
so make sure you're reporting the correct one.
Mhm.
Because once again, as we also discussed before, if you have a code that's a CPT code and an ICD-10 code that matches, you're going to get paid. So you could be thinking that you're doing everything
You're
right.
fine. Right.
And then comes the request and they look at the records and it says, no, you didn't do both. You only did one. So it shouldn't be
Mhm.
this code. It should be this code. So now you owe us back, all this money.
Right.
Now this is an abuse issue. You didn't know, it's not a fraud issue, but you still have to
Mhm.
pay the money back. You still didn't
Right.
deserve it. So it
Right.
still has to go back to them. So, you don't want to get one of those where they say, oh, well, we found that you did miscode these. And so now
Mhm.
you've been doing that for 5 years. So now you owe us $600,000. I mean, who can write a check like that? Just, okay, here you go.
Nope.
Not many practices can do that. So then you have to
Nope.
get on payment plan to pay it back. And then they come back and watch you
That's right.
because you did do it
Right.
incorrectly. So now they're going to check back with you in 6 months. They're going to want more records, so it just, these mistakes
Mhm.
um, as they're made, even though they're not done purposely. That's what I was looking for. Even though they're
Yeah.
not on purpose, you still have to pay it back
That's
and you
right.
still get watched for it. So it
Mhm.
still costs you and continues to cost you
Yes.
until you cycle back
Yes.
through and prove to the payor,
Mhm.
especially if it's the government payor, that you're doing it right. Once
That's
they
right.
know you're on the right track, they're okay then. But for a while, they're going to keep an eye on you and make sure that you do have your ducks in a row now with it. And that's just costly for the practice because not
Yeah.
only did they have to pay it back, but now, they're having that additional scrutiny. They're probably
Mhm.
using our services, a
Mhm.
little more than what they would have if they've been
Right.
doing it right in the first place. So instead of doing a
Right.
6-month check twice a year, we're in there every month having to look at records to make sure
Mhm.
they're continuing to do it right.
Right.
And that's going to cost them extra money. So, just getting it on the right footsteps to start paying attention to those CPT descriptors
Mhm.
is going to help just keeping everything running smoothly, getting the checkups from people like Sonal and myself to make sure that, yes, these things are all good. Or if there is an issue, you catch it right away. It's not 5 years worth of an issue. That's the things that you want to make sure you're doing when you are one of the good practices, doing the right thing. So this is how to stay away from becoming a caper, from us talking about you.
Wow, Betty. So well said.
I'm
Everything.
sorry, I just got
Absolutely.
on my
No,
roll
no.
there.
Absolutely. No, no. That was so well said, right? It would be so much better for practices if they were able to find in their budgets room to retain certified coders on staff, right? The chances of you making these types of egregious errors are going to decrease tremendously if you retain the right certified professional coder on staff at your practice, right?
Yeah.
And then additionally, right, because that person is going to be in-house, their eyes are on your practice, excuse me, every day. They know your ins and outs. They know everything really, really well. It's really good to get outside eyes in your
Yeah.
practice from time to time. Like we say here on Compliance Capers all the time, it's really good to get fresh, objective eyes in your day-to-day work on claims and then coordinating documentation, right? It's just good to do a spot check
Yeah.
every 3 months, every 6 months, every year, whatever your budget allows you, right? Because that's even greater protection.
Yeah.
Because like Betty was addressing so eloquently. On the back end, if you happen to be caught up on trying to clean things up on the back end, it becomes very, very costly, right? Very, very costly doing things on the back end rather than taking the proactive approach that we stress here, is going to just go so much better for so many practices in the long term. Because then when you are audited by a payer, commercial, government, whoever, you can fly through that audit because you've already been looked at, right? You've already retained a certified coder on staff who knows the CPT codebook, who understands how to read all of the definitions after CPT, right? Because as you were explaining so well, there's that semicolon, then the word and, then the, bifurcated bullet list underneath with all of the additional CPT codes that happen to follow. If you don't know how to read that, right, you could, mistakenly choose the incorrect CPT code because you didn't acknowledge that semicolon and then the word and, or the word or, right? And then you're picking the wrong CPT code. And then when you get people like us taking a look objectively, as external people who are auditing, that's an additional layer of protection, a cushion, right? That we've given you the go ahead. These look great. Everything is fine. Your documentation doesn't require additional tweaking. Everything has been followed properly and appropriately. So yeah, the back end of things, because that's where a lot of our strengths happen to fall as well, helping clean things up. But we do know that that becomes rather costly. So again, it's all about making sure that your reimbursement is appropriate the first time, and then you're not having to send back checks when they come to recoup those mistakes and errors, which again, we've stressed this in episode after episode here on Compliance Capers, is they will take the volume and start extrapolating, right? And making the numbers grow from just those few claims that we found in the month of January. They'll take it way back and then blow everything up to a different proportion level. And like Betty was saying, nobody can just write a check. Not many of us can just write a check for 600 grand and be done with it and expect we're done and we're off the hit list, because no, you're not off the hit list. You're still being looked at closely for quite some time by the government. So you're not free and clear just because you happen to write a check. So you made some amazing, eloquent points there for today's episode. So I really do hope that people get a lot of takeaways here from our conversation today on upcoding services, because it's just not a good look. You need to code things correctly based on the service you provided to your patient at that encounter, and then document it appropriately. So everything can be cleanly done the first time. You don't want to wait and see what happens to you later. No,
they'll get to you sooner or later.
They sure will, as we know, Betty. Oh my goodness, my friend, thank you so much for coming on today on our Compliance Capers. This is such a good idea that you and I developed together. And I really do think our audience is going to get a lot of great information from our weekly sessions at the end of each and every week, every Friday. So I can't wait to see you again next time, my friend.
I know. Tune in, y'all. Bye.
Bye. Thanks so much. See you soon.
Thanks.